we welcome you to our presentation called the Cardiff Model, Public Health, Community, and Law Enforcement Partnerships to Prevent Interpersonal Violence. We're really excited to share some of the experiences we've had with translating this particular violence prevention model in a few different sites in the United States. I'm joined by a number of colleagues across Milwaukee and the Atlanta area. I think it would be best for us to quickly all introduce ourselves so everyone can get a sense of how we fit in with the presentation and the two different implementations. I'll start. I'm Jennifer Hernandez-Meyer. I am a assistant professor of emergency medicine at the Medical College of Wisconsin. I am with the Milwaukee translation, as we'll probably refer to it during this presentation. We have been working since 2015 to implement the Cardiff model in 2 different sites in the Milwaukee area. Steve, you want to go next?
Thanks, Jenny. Hi, my name is Steve Hargar, and I'm a professor of emergency medicine at the Medical College of Wisconsin and an affiliate faculty at the Comprehensive Injury Center.
Sarah?
Hi, everybody. I'm Sarah Kolbeck. I am the director of the Division of Suicide Prevention at the Comprehensive Injury Center at the Medical College of Wisconsin, and I am the data manager on our translations in Wisconsin.
Mike?
Hi, thanks for having me. Mike Levis, pediatric emergency medicine physician at Children's Hospital and the associate director of the Comprehensive Injury Center at the Medical College of Wisconsin.
So we'll move, or since we're kind of in the Milwaukee area, Jamal, do you want to introduce yourself?
Sure. Good morning. Jamal Smith, Violence Prevention Manager for the Milwaukee Health Department, Office of Violence Prevention.
Excellent. So that's kind of the presentation team from the Milwaukee area. And then everyone who's remaining is from the Atlanta metro area, translation of the Cardiff model. So let's start with Grady Memorial. Dan.
Thanks, Jenny. Good morning, everyone. My name is Daniel Wu. I'm an associate professor of emergency medicine at Emory University, and I'm the interim chief of emergency medicine and the chief medical information officer for Grady Health System.
Excellent. Jasmine. Are you muted, Jasmine?
Can you hear me now?
Yes.
Okay. Hi, everyone. My name is Jasmine Moore. I'm the injury prevention coordinator in the trauma program at Grady Memorial Hospital.
Excellent. Sergeant Frazier.
Yes, I'm Dave Frazier. I retired from DeKalb County Police and started this project early 2014.
And then we are joined by some folks from the CDC. Ashley.
Hi, I'm Ashley Dean-Berno. I'm a behavioral scientist in the Division of Violence Prevention at CDC.
Laura.
Good morning. My name is Laura Kohler. I'm a behavioral scientist, also in the same division as Ashley.
And is Daniel on?
No, he's not on.
Okay.
Didn't join too.
Excellent. So we have a large group of individuals who have experience with translating the Cardiff model, or at least the initial stages of translating the model. We'll each have opportunity to provide some insight and some lessons learned. I hope that we have a lot of the way that this is structured is that we're going to provide an overview of the public health model for violence prevention, the Cardiff model, talk a little bit about the implementations at each of our sites, and then get into a little bit of lessons learned in terms of stakeholder recruitment and integration into everyday practice. Talk a little bit about data considerations, and then some particular lessons learned from our sites. But I think that, or I hope that we have a lot of time for Q&A to answer any questions that any of you have who might be thinking about implementing the Cardiff model and what to think about in the initial stages. So with that, we'll start with violence is a public health problem, and I'm going to allow my colleagues at the CDC to start us off.
Great, thank you, Jenny. So violence has lasting impacts on health, both in the short term and the long term. If you could, thank you. Its impact is not only in terms of the physical injuries received, such as internal injuries or injuries to the head, fractures, cuts, and burns. You can go ahead and click again. But we also know that studies show that violence is associated with developing chronic diseases such as cardiovascular disease, stroke, cancer, diabetes, alcohol use disorders, STDs, including HIV, obesity, and lung diseases. Violence is also associated with risk behaviors such as smoking, alcohol and drug use, physical inactivity, unsafe sexual practices, and having multiple partners. And violence also affects maternal and child health, seen here in the kind of sky blue color. It could result in pregnancy complications, fetal death, unwanted or teen pregnancies. Needless to say, the impact that violence has on an individual's mental and emotional health. Violence has been associated with depression, anxiety, PTSD, eating or sleeping disorders, as well as suicide. Next slide, please. Nonetheless, we know that violence is preventable. At CDC, we take a 4-step approach to address public health problems, including violence. And these steps, commonly known as the public health approach, are the ones that you see here on the screen. During the first step, starting kind of from the bottom, we define and monitor the problem. We do this systematically by collecting data to determine what is the problem, who is affected, where, when, and how. And data are typically gathered from a variety of sources, such as things like death certificates, medical or coroner reports, hospital records, child welfare records, law enforcement, or other records. Data can also be used by being collected from population-based surveys or other methods. In the second step, we identify risk and protective factors that are associated with that problem. That is the reasons why one person or community experiences violence when another one does not. Scientific research methods are used to identify the factors that increase the risk for violence. And these are called risk factors. Factors that may buffer against these risk factors are also identified, and these are called protective factors, which decrease the likelihood of violence. The goal of violence prevention is to decrease risk factors and increase overall protective factors. In the third step, we develop and rigorously test prevention strategies as to identify what works to prevent the problem from happening. This information is then shared with others, usually through our 4th step, which is ensuring the widespread dissemination of those identified evidence-based strategies. The strategies shown to be effective in step 3 are disseminated and implemented broadly. Given many prevention practitioners may not have the skills or resources necessary to conduct steps 1, 2, and 3, it's important to know where to find information about what are the best strategies to prevent different problems. So for example, registries of evidence-based practices, training and technical assistance programs, among others. And even though step 4 is considered the final step of our model, it doesn't mean that that all components of the strategy fit within the particular community context to have this desired effect of preventing violence. The next slide. So now I'm going to provide you with a brief overview of the Cardiff model. The Cardiff model is an effective strategy to prevent violence. It accomplishes this by building a partnership between hospitals, law enforcement, and the community. Hospitals collect anonymous injury data that occurs in public places. The information collected is general, simple, and anonymous. So for example, a person got hit with a chair at a certain club on Friday night around 1 a.m. And we would then compare this incident to existing law enforcement data to be able to identify whether that incident was registered by law enforcement. And we would then be able to see if we found a match or not. And this aids in identifying locations and patterns of violence not known to law enforcement, which we can then use to inform our prevention efforts. Next slide. So the Cardiff model began in Cardiff, Wales in the UK. And as I mentioned, it's anonymous hospital injury data that's compared to law enforcement data to reveal new or existing hotspots of crime. We're asking about where did the injury occur and what day and time did this occur? And then this information is used to inform place-based violence prevention programs through community safety partnerships. Next slide, please. So we know that Cardiff is effective because it decreases violence and it's also cost effective. Research in Cardiff, Wales showed that there was a 32% reduction in woundings, which is a behavior or crime similar to aggravated assault in the United States. And there was also a 42% reduction in hospital admissions for violence-related injuries. And we know that for every dollar spent on the Cardiff model in the UK, there was nearly $15 saved in health system costs and more than $19 saved in criminal justice costs. Next slide, please. The Cardiff model is effective and useful in deciding which evidence and community-driven interventions to pursue. So ideally, a local Cardiff model community safety partnership would use this data to identify where and when violence is occurring and create collaborative solutions to prevent violence. Partnerships include representatives from hospitals, law enforcement, police, and community leaders or organizations. Based on this information, interventions to prevent violence can be chosen, implemented, and then evaluated. And successful solutions in the UK have ranged from environmental changes, such as widening sidewalks and increasing lighting, to policy solutions, such as toughened glass that might prevent the use of glass bottles as a weapon in bar fights. Throughout time, it's important for the Cardiff Model Partnership to continue to collect data, examine maps, and develop or adapt the interventions based on the community's needs. And the process of collecting, sharing, and storing the data provided by the hospitals and police agencies must be determined and approved by the members of the local Cardiff Community Safety Partnership. This, given that there are different laws and regulations that could vary across entities, jurisdictions, and countries. Next slide. So the CDC has developed a Cardiff Model Toolkit available on our website here. It includes 2 posters, several guidance documents, an overview, a document on hospital, law enforcement, legal, technical, and financial considerations, partnerships, as well as some information on communication and media. And we have also included a readiness checklist. Next slide. So I'm going to turn it back over to you, Jenny.
Yeah, so thank you for that, Ashley. I would, since we have so many panelists and just a wealth of knowledge about the Cardiff model. Before we move on, I want to welcome any additional points from my fellow panelists that they would like to stress about the Cardiff model before we get into our different translations and lessons learned. We covered it? All right, great. Let's see. Okay, so the next, I apologize, I have a small dog. So the next section I thought that we could talk about are the community stakeholders. As Ashley mentioned, a big part of the Cardiff model is not only collecting the data, but collecting and recruiting multi-sectoral, diverse community of stakeholders who are vested in reducing violence in their corresponding communities. And the stakeholder recruitment will look different for each of the sites. For example, many communities already have some safety committees or safety task force assembled. And that is a great starting point for a Cardiff translation in that particular community. This might be new to a community as well, and would require a lot of thought into who should be around the table. We all have different perspectives of violence in the community. And so when the information from police and public health and healthcare are presented to the community, who has unique perspectives about how that data can be utilized and can help to strategize prevention activities. For example, our translation in the Milwaukee area includes law enforcement. We have a mayor, we have fire, we have interested residents, a lot of interest from the agencies that serve the different areas that the data are talking about. And then we have a lot of individuals from the hospitals that are actually collecting the Cardiff data. One of our translations in the Milwaukee area, the city of Milwaukee in particular, had already had a rich history of working with the community, and I'll let Jamal talk about that a little bit later on. Our other area in West Allis, Wisconsin, this was kind of a new area for them. And so me and Sarah Kolbeck, who's on here, actually had to set up individual meetings with a lot of people and talk about the Cardiff model and recruit that way, and kind of a snowball sample. So once we recruited someone, asking who else should be around the table and getting referrals from the people who are interested, because that they know the people in the community who should be around the table. So recruitment will look a little different for each Cardiff model translation of stakeholders, and who's going to be around the table might also look different, not only for each translation of this model, but perhaps for each meeting, or as data show different areas of hotspots, you might add new stakeholders around new hotspots of data to help strategize around prevention in those particular areas. So some of the strategies that we've used to engage stakeholders is framing the model as a time-sensitive, data-driven method for reducing assaultive violence. Stressing that it links data, so it might provide more of a complete picture of violence that occurs in the community. Stressing that it creates that enhanced information system that the police data sets might show one thing, the hospital might be serving different areas of violence. And one thing that we did in Milwaukee is we've actually also brought in EMS data, because we know that some of the literature indicates that there are unique cases of violence that are only seen by EMS. Perhaps there is an assault treated by a paramedic or an EMS provider, and that person might refuse transport to the hospital. And in that case, that incident of violence might only appear in an EMS data type system. And so stressing to stakeholders that this might provide more unique information, and that it's a public health population based approach. It's not here to adjudicate any violence. It's a population based approach. We're not interested in drilling down and trying to understand the specifics around one case in terms of that person. It's anonymized data, and some of the folks in the community are relieved to hear that it's population based. We're not trying to single out anyone. We're just really trying to reduce violence in the community. So that's a little bit of the strategies used to recruit stakeholders. I'm going to send it over to Sergeant Frazier, who will provide. So the next set of slides, we're really trying to engage all of our different sectors of partnership who have been involved. We'll have a law enforcement perspective, and then sort of a public health perspective, and then a few perspectives from integrating the Cardiff model into healthcare in terms of collecting the data and also getting stakeholders within that area. So I'm going to let Sergeant Frazier take the next piece and provide information and anything that he thinks is important for consideration for the law enforcement who might be considering the Cardiff model.
Okay, so Sergeant Dave Frazier. I'm retired from DeKalb County. Retired in 2019, but in about 2000, I guess it was about 14, I was an aide to one of the assistant chiefs, and he asked me to find a project that was going to be pretty innovative for the department. And there were a lot of things that the department was already doing that was considered innovative, particularly like with mental health. We had a mental health unit where we had officers assigned with a clinical nurse to go out and follow up on all our mental health cases. And we'd had that unit for about 20 years. And it was one of the first in the state, and could have been very well in the country, but it had been such a success. We were looking for something different. So I got looking on the internet, and I came across the Cardiff project and saw that it was sponsored with the CDC. So what I did was, knowing that the CDC is in DeKalb County, based in DeKalb County, I contacted the CDC and I ended up speaking to Tom Simon with the CDC and asked about the project. And he gave me some details. And with that, I was able to do a presentation memo to my supervisor, the assistant chief, who then presented it to the chief and chief of police at the time. And the project took off from there. The advantage, the thing we liked about the project was the fact that this was anonymous data. So it didn't really, didn't count against our UCR or our NIBRS numbers. And so this was extra data that we were gaining that didn't really involve any investigative, more investigative work for our detectives. And when you looked at the FBI statistics, I think they said that roughly 48% of all violent crime is not reported to the police. And this would give us an opportunity to collect this data and then to map this data. So I had to present the case to the county, and the CEO of the county and the CEO of the county and the commissioners gave approval for the project to go forward. And with that, I enlisted a fellow worker, Detective Charles Flood, who had extensive knowledge in computers, and we got the project going with the CDC. We had set it up so that we had already had crime analysis computer program through Omega Systems. And we contacted Omega and asked them if they could incorporate a separate dashboard just for the data that came through from our Cardiff project here. And they were happy to oblige us on that. And the way our crime analysis works is you get a picture of the entire county of how where the crimes are occurring. And then each officer has access to it, and they're able to zoom into their particular territory that they work, and from there they can look at the crime analysis data and see where crimes are likely to occur and approximately times when it's going to occur, and from there they can then act upon it. And the integration of this data, from which is anonymized data, is great because it gave us an idea where there were things that were crimes that were unreported to us that we were able to capture. So when I left the department in 2019, I retired. We had done this an internal study, and we had determined we had about at least 22 community outreach projects going, and this would be had been a continuation of our community outreach programs. And the department really embraced it. And when I left, it was still going. And I checked just recently with them, and they're still working on the project. So it's good to see that the department embraces it. The new chief has also embraced it, and it's good to see it's still going on. But what we did was, real quick, was after we got this data, I kept the command staff informed, and then, like I say, the individual officers had an awareness of the program because of the fact that they had the daily Omega crime analysis data, which incorporated the Cardiff data. So it was a great tool for the department. And going forward, it's I would think most departments should embrace it because it really it doesn't count against your NIBR numbers, UCR NIBR numbers, and it doesn't cause any more investigative work for your department. Now, you could find a situation where you have a cluster of unreported crimes, and that might point to some type of gang activity or something of that nature. But that would fall upon the patrol officers to go out there and maybe identify what could be contributing to these unreported crimes in a certain area. And then you could, of course, focus more of your patrol or specialized units on those areas. So it really isn't anything. It's very easy for law enforcement. The hard, heavy lifting is through the hospitals and the collecting of the data and making sure it's anonymized. For the police department, all you have to do is share your data. We share our data. When we were leaving, we had set up to where we could share our data with the state. So they would get that data anyhow through the GBI. So it's a win-win for police departments and for the community that the police departments serve. That's it.
Thank you, Sergeant. Just for us kind of novices, would you mind going into a little bit more detail about when you say it doesn't count against your neighbors? Can you clarify just to make sure everyone on like understands that point?
Yeah, so, you know, every crime that was reported to the police department, we have we goes into our crime totals. And so we have to report those every month to the state. And if the crime is reported, of course, it goes through NIBRS, but it goes through UCR NIBRS. But this is unreported and it's coming through anonymized data. So it didn't count against our NIBRS numbers because we didn't have an incident report for it. And in order for our NIBRS, you gotta have an incident report, exact location, the type of crime that was committed, the victim or possible victims, and of course then a narrative and witnesses and all that. And you don't have that with this data. So all you have is the fact that it was reported, it was collected anonymized through health, through either the hospital, which in this case was the hospital. And so you're able to map it, but it doesn't show up as an actual statistic of crime. You understand what I'm saying? It's icing on top of the cake, so to speak, because it's not a crime that you don't have enough data to investigate to identify a perpetrator. All you're doing is you're gathering data of an event that occurred, but it's not actually been reported. So it's a win-win for law enforcement. Does that make sense to everybody?
Yeah. Thank
Okay.
you. Thank you for that.
Yeah. This is Steve Hargar. Sergeant Fraser, these are very important points to be making to pull in law enforcement agencies as partners in this translation. So your comments about it being a win-win for law enforcement are really quite helpful in engaging skeptical law enforcement agencies who might not necessarily understand what they're gaining through this Cardiff model. So thank you so much for your comments.
Yes.
And so Sergeant Fraser is going to stick around. So if anyone has Q&A for him from the law enforcement side, feel free to start thinking about what you'd like to ask him. I would just like to note that I believe we have Dr. Jonathan Shepard on the presentation, who is one of the co-founders of the Cardiff Model in Cardiff, Wales as well. So we're really excited to have his expertise on, and perhaps he would like to chime in during the Q&A as well. We're very pleased to have him, if he's still around. I don't know if he has to scoot off at any time. So that was the law enforcement perspective. We are also joined by Jamal Smith from the Office of Violence Prevention at the Milwaukee Health Department. So in our Milwaukee translations of the Cardiff model versus, so just if you remember, we'll kind of say Atlanta versus Milwaukee. So in our Milwaukee translations, we are translating to kind of two areas of the Milwaukee area. And this setup might look different for different translations, but we are having the health departments in those areas take the lead. We've identified them as the poised and a really good place to start and to convene those community conversations. So I would invite Jamal right now to let us know what he thinks are important considerations from the public health side of things.
All right, good. Thank you again, Jenny, and good morning. We are definitely honored to be a part of this work with the Office of Violence Prevention. Our objective is really getting people to understand the complexities of violence and viewing violence more from a public health lens than a punitive or law enforcement or just almost like a punishment lens, right? And that's nothing to say against law enforcement, but it's also trying to elevate and understand that there are multiple ways in which we must address violence. So when it comes to the Office of Violence Prevention, our office has been in existence since 2008. And initially, the objective was to really focus on domestic violence across the city of Milwaukee at the time, where domestic violence was very pertinent and prevalent within the city. However, within 2016, there was a change in sequence of focus within the Office of Violence Prevention, because in 2015, we had seen one of the worst years of violence in Milwaukee history. We had gone from 86 homicides in 2014 to 145 in 2015. So there was a charge that became very much important to Mayor Tom Barrett and community stakeholders on ways in which we could start to address violence from a preventative model. And within that process began those conversations, there was birthed the process of the Blueprint for Peace. And our Blueprint for Peace is a comprehensive violence prevention strategy, a strategic plan that was created by the community for the community. The idea was for there not to be a bureaucratic approach to this, but for there to be an all-inclusive conversation that would bring about the participation of community members, stakeholders, business executives, policymakers, the health departments, hospitals, to really have this discussion on what are ways in which we can elevate violence prevention strategies. So this was a 12-month process. We gathered focus groups, steering committees, youth participation. Over 1,000 youth participated in this process, and most of them have been in situations where they have been affected by violence. Who better to have a conversation with about violence than those who have been potentially or have been directly or indirectly affected by it? So we were able to compile all of this data and create this blueprint, which really has become not just a plan that works or that has a presence in Wisconsin, but that has also gained some national traction, where there are other health departments, and whether it's Office of Violence Prevention or the Office of Neighborhood Safeties, that are reaching out to our office to figure out the ways in which they could create their own blueprints in their respective cities. So when it comes to the Cardiff model, the idea was to have the same process, right? How can we come together with key stakeholders and partners to really analyze the trends of violence that are happening in respective neighborhoods? We started with the District 7, which is one of the police districts in the city. Well, since I've been here, we've been working within District 7. And one of the pilot neighborhoods is a neighborhood called Sherman Park. And the idea is really to analyze a lot of the violence, whether it's homicides, domestic violence, overdose deaths, suicides, and really figure out where are the most prominent geographical areas that have been impacted by each of these issues, with the idea of creating place-based solutions in those respective areas to provide some form of resolve and solvency for the neighborhood. Now, make no mistake, we understand that many times homicides or issues of violence tend to happen within the homes. We understand that. But there are also times where there are situations that happen outside within the environments themselves, and trying to figure out what are ways in which we can solve those issues, in addition to what are ways in which we can have conversations with residents about what are some of the needs within the neighborhood. And I think that's what makes it so important to have community stakeholders at the table, such as we have the Sherman Park Community Association that is there, and they have a very large presence within that community. We have an organization called Safe and Sound, which has community organizers that focus in particular neighborhoods across the city, Sherman Park being one of them. In addition to that, we just have residents that have an interest to participate in the conversation, right? So it's just bringing together existing organizations that are already doing work within Sherman Park and building partnerships with the Medical College of Wisconsin, with the Office of Violence Prevention, with the Health Department, with the Milwaukee Police Department and the Sheriff's Department, as well as analyzing data from the medical examiner, from Freighter and local hospital institutions across the city, with the idea of just analyzing this data and figuring out how can we use this data as a means to really elevate work that is happening or work that needs to happen at a more grand level within those neighborhoods, and then build a critical mass of collaboration so that we can increase capacity around the service. I'm glad that Sergeant Frazier made the comment about participation in terms of law enforcement, because we are now seeing that potentially increase in Milwaukee. There was some hesitation. That's why Dr. Hargarden was asking the question. There was a little bit of skepticism on behalf of the Milwaukee Police Department, but now we've seen with the change of administration that there's becoming more support within that work, which Sergeant Frazier, if we can connect after this so I can get you to have a conversation with some of the law enforcement representation, that would be great. But just the idea of leveraging those partnerships that are already present within the neighborhoods, in addition to the work that is happening within hospital institutions, as well as the public health department, is really bringing about a robust plan and a robust movement and campaign around authentic violence prevention.
Excellent. Thank you, Jamal. And again, Jamal will be around for the Q&A, so think about anything you want to pick his brain about. He is, as you can tell, very knowledgeable about strategies for violence prevention and how to integrate Cardiff and the data into those activities. Let's see. Now we'll talk about healthcare considerations, and we are joined by our partners in Atlanta, and also a pediatrician from our Milwaukee area as well. So there are different considerations for each hospital, each healthcare system. And so I think they're going to provide a really good overview of at least some of those considerations, even just by location and population lessons learned. So Jasmine and Dan.
Thanks, Jenny. Good morning, everyone. And I think it's great to hear all these views on and viewpoints on Cardiff. And as my co-panelists have already eloquently described, the goal of Cardiff really is to identify that the violence that's not reported in communities and combine that with the violence in the incidents we know is reported to create these richer, better maps that we can give to public health and law enforcement and communities to do those interventions. And you're already hearing about the end result from Dr. Frazier and Mr. Smith about what could be done with better data. Unfortunately, we know from the literature that anywhere between 50 to 90% of all violence is unreported. But it certainly makes sense that some of that unreported violence ends up in the hospitals with victims trying to be seeking care for their injuries. And I know in my hospital, we're a level 1 trauma center. Often the severe violence, the known violence, like gunshot wounds or stabbings, people know about already. And in fact, often in our trauma center, the police will follow in a gunshot wound victim because it's been reported already. The violence that we really need to capture, which is more difficult, is the violence that presents with injuries that aren't apparent that it's due to violence, such as lacerations or bruises or broken bones. And that requires us asking patients exactly what happened, and if this was intentional or not. And so if you can imagine, that's quite a lift. And the goal is to ask every single patient who presents, because if you don't ask, they may not tell you. It's like with domestic violence also. And so you have to really find the best method within your hospital to do that. And it's going to depend on your workflow and your, who's bought in and your resources. In our particular hospital, the nurses really are the glue that holds everything together. And we're already being asked to do triage on many conditions, such as suicide identification, depression, travel screening or infection screening. So it made sense for us to put this violence screen in that same workflow. And so we went to our nurses and we got buy-in and champions for that. And it was very important. And that probably is the most important step for us, is that, and we were really, really cognizant the entire time to make sure that we were not trying to overburden the nurses, that they were bought in and they understood that this was part of the mission of the hospital, which I'll just describe in a moment. But we actually had them give us input on how best to screen the patients. They actually made edits to our screen. We actually surveyed them to see if this was what they thought was part of their mission. And we found in the mid 90s that they thought this was part of what they should be doing to protect patients in our communities. And so they were really bought in, and that really helped us with getting this implemented. In our particular ED, our intent was to screen everyone. And so we put it into electronic record and we built an electronic screen that would stop as soon as they no longer met the criteria for the information we collected. And I'll give you a good example of that. As you've heard over and over again, this is not a policing project. This is not to give personal information. So if the violence took place at a home, in a personal address that could be used as an identifier, we just stopped the screen there. And so the nurses would not have to collect additional information. It would end it as soon as possible. And so we made sure that it took time to iterate and educate all the nurses to do this, to get buy-in. And then we, on the back end, would clean the information to make sure that no anonymized information would end up being sent to the police department or to public health. And this took a little bit of training and time also. And then eventually we actually made this automated so that on a monthly basis, we would share the information with public health and in our law enforcement agencies. And again, it was all anonymized data. And I do want to say that traditionally healthcare has been, we take care of patients within our own walls during set visits, but that's changing. We really need to take care of patients all the time. And this means, we can take care of their injuries, but preventing their injuries should be our goal. And we know that the health and the early morbidity or mortality of people, small amount of it changes based on what we do internally in a hospital. It really is all those social determinants of health, the socioeconomic factors, what happens in society, where they live. We know zip code is directly related to how long someone lives. And so if you translate that and you communicate that to the hospitals and your colleagues, people understand that we can't just wait for patients to come to us. We got to do things to get into our community to make them safer. We're also a level 1 trauma center, and so our mission is to reduce violence. We would be happy if we were out of business in this area, and so it certainly fits in within our goals and the mission of our healthcare system to implement something like this for Cardiff. And with that, I'll turn it over to Dr. Levis or Jasmine if they have additional comments.
Jasmine, would you like to add anything?
Not to that, Dan covered everything perfectly.
Excellent. And so let me, Mike?
Yeah, thanks guys. Again, good morning. So yeah, I'm going to talk a little bit about our experience in Milwaukee with Children's Hospital, because I think it's good to compare and contrast. Our healthcare system in the United States it's not a universal healthcare system, right? It's not a single government system. So there's multiple stakeholders, multiple different entities that all have different medical health records, that all have different leadership. So our journey at Children's Hospital was actually probably on the spectrum of one of the early adopters and easier to implement. In 2014, when we started talking about doing this, we approached children's leadership and really had buy-in from the get-go. The CEO at the time and nurse leadership thought it was a great idea, thought it really fit with our mission and our goals. Our trauma service thought that, you know, they could double dip a little bit here and utilize this screening to also inform some of the data that they use to maintain level 1 trauma status. And you know, with that buy-in, we actually, I think, in Milwaukee, amongst all the hospitals that have now successfully been integrated into our collection, we're, I believe, at 5 total hospitals, with 2 others that are collecting and almost ready to be putting into the consortium's data. You know, we again, were able to really early on get buy-in from the top. And then it was really important for us to get also this groundswell like they did in Atlanta with nurse leadership. So we, from the get-go, have had a nurse champion who really pushed and advocated for why this was important. And this nurse champion wasn't necessarily a nurse leader in label, but a nurse leader in reality. So this was someone that was respected by her colleagues and was known as someone who, you know, was also in the trenches, right? At Children's in Wisconsin, we are the level 1 trauma center for youth. We see 70,000 visits a year. We average about 70 gunshot victims under the age of 18 a year. This year we almost doubled that, unfortunately. But we are definitely the place to catch or to get all that level 1 trauma. But on top of that, we also are the catchment. We're the catch-all for the area. And to Dr. Wu's point, you know, a lot of those, you know, gunshot wounds, law enforcement already knows about. But what they don't know about are our fights, the fights that happen in the city. And we know that those minor injuries lead to more serious injuries down the road. So we're able to collect those by implementing the Cardiff model, by implementing the screening. And we did it much in the same way that they did in Atlanta. we integrated it into triage because nursing grabbed a hold of it and they said, yes, this is where it should be. It should be on the front end. And to date, since 2015, we are currently at a place where 98% of all of our patients get screened for this. And we've been able to maintain that with nurse buy-in. Part of the ways that we maintain that is we've continued to have the nurses involved. We have 2 nurses that live in one of the communities where we have a community consortium, and they actually come to the community meetings, both as collectors of the data or the information, and as community members who live in the the neighborhood where we're trying to implement react to the data. We've also with publications, our nurse champion is a co-author in our major publication to date. So maintaining that engagement in the academic portion, I think, has also been a way that we've been successful at Children's. There were early on some considerations, especially with involving, having children. There's reporting considerations, and we tied that into what our standard practice was already with being mandated reporters. So we kind of addressed that up front. There was a little bit of discussion. It wasn't really reluctance to share detailed information about children, but more making sure that we were being very cognizant of individual rights and HIPAA rights and those sort of things. But the fact that this is anonymized data, that it doesn't, it's not used for education, has really enhanced our talking points when we have anyone who is fearful about sharing data with youth. And then, there is concern that a lot of the youth are accompanied by, we're not getting the direct information from the youth. But in most cases, it's an adult, it's a caregiver, it's someone who's trusted. And actually, in the five plus years that we have been doing this, our data has been pretty reliable, pretty accurate. And again, it's a screening process. So there are some that we miss, but I do think that we get quite a few. Some of the things that have impacted us directly at Children's is about 45 to 50% of our pre-COVID of our injuries were happening in or around schools. And one of the reactions that Children's had to this was, we're up to 11 schools where we have school nurses that are employed by our hospital, so that we can try and stem a little bit of that and have kind of an inside participant in those schools that we're having some of the more severe injuries from, or some of the more frequent injuries from, and a way to try to have a presence as a hospital in the public sector, in partnership with the school, to try and figure out how we can abate some of these injuries before they make it, it escalate to get to the hospital level. The other thing that we noticed, because with Cardiff, you can look at time of day, was that the most, again, pre-COVID, the most dangerous time to be a youth in our city was right after school. That's when the vast majority of our youth injuries were happening, and that has led us to have discussions about safe busing, safety after school. How do we really look at elevating our resources in the city at those times. Again, with COVID, schools have been shut down, so that trend has changed. But again, I'm expecting once we go back to school that those discussions about interventions will happen again. So again, Children's is an early adopter. We have some interesting stories comparing all of our sites across the city, all of our hospitals across the city, and we'd be happy to share kind of comparing and contrasting if you guys have questions later. Thank you.
Thank you, Mike. The next section, I think we have about 15 minutes left. We're going to quickly talk about data considerations and data use agreements. The sharing of the data and the collection of the data in the hospital are, the key points of Cardiff, and there are a few things that we have learned. So Ashley or Laura?
I can go ahead and start, and if Laura has any additional things, she can jump in. So how data is shared in these data use agreements depends on whether or not a public health agency is involved. In our case, in the Metro Atlanta area, a public health agency is involved. We've asked Georgia Department of Public Health to create a central data repository. So they're responsible for combining hospital and law enforcement data to then produce these community violence maps, where we are able to identify where violence frequently occurs. And then we can use those maps to share with our partners to inform our violence prevention strategies. But as you can imagine, all sharing of hospital data must comply with HIPAA requirements. And as several of the other panelists have noted, patient-specific information is not shared, only the location and the timing of violent events. And as I mentioned before, we have a Cardiff Model toolkit. There's a specific section in the toolkit on legal, technical, and financial considerations if you have specific questions about what this looks like, because each local public health agency should ensure compliance with your local and state laws. Next slide. Jenny, are you there?
Sorry.
That's okay. Did you want to review this slide?
Yeah. So additional data considerations. Like we've said throughout, whomever is the data receiver, it's going to depend on your particular setup. So in Milwaukee, the medical college receives data from the hospitals and the police. I know that in Atlanta, perhaps it's a different setup. And so depending on who's receiving the data, there has to be considerations of potential IRB approval if it's an academic environment, such as the Medical College of Wisconsin. And because of that additional approval that's needed, there might be some limitations put on the types of data or different protections that you might have to consider in terms of making sure the data are secure. But really just stressing that any partnering agency with geomapping capability can take the lead on receiving the data. As we've mentioned and as mentioned in the toolkit, public health has a history of receiving all sorts of data and might be poised to receive the data
think she may have froze.
Jenny, are you there? Yeah, she may have frozen. Ashley or Laura, do you want to continue, or is
I think actually I have the next the next part in the slides, and I can share my screen if that would work. It looks like I have that ability. And then I can kind of take it from there, if that's okay with everybody.
Yeah, I think just before you do that, Sarah, I just want to reinforce this point that Jenny was just starting to talk about, and also point out the challenges that hospitals are perhaps going to be raising in terms of HIPAA, that the hospitals will not tolerate any implication that they're sending information to the police. And so law enforcement really, in this case, is not necessarily going to be taking the lead in presenting these geocoded information from both sites. It's really, I think that's why it's so important for the public health department to traditionally be taking the lead in terms of having this information be brought together for an enhanced map that has been discussed. In the medical college, we serve as that honest broker in an intermediate way that has worked very, very well. But I want to really emphasize that hospitals are not going to tolerate any implication that they're sending de-identified information, any information to law enforcement.
And if I could add to that, Dr. Hargard, I agree with you. And I mean, it is something where we always needed to be aware of patient trust implications, but hospitals are also already sharing data organically and naturally through other disease processes with public health, such as STDs and things like that. So that relationship is already in place for one, and often the method to share is already in place. So that's a natural relationship that can just be leveraged, and it conforms to HIPAA as well. And so it seems like a natural pathway that public health would be to store this data, to be the receiver of it.
Absolutely, great points, Daniel.
So I'm going to go ahead and move us along. This next section is mine. And again, thanks so much for those of you that have joined us this morning. Again, my name is Sarah Kolbeck. I am the data manager for the Milwaukee and West Dallas translations of the Cardiff model. And I'm just going to talk quickly about kind of the process of combining the information that we are receiving from a number of sources, and then how I prepare that to share with our community partners. And so a little bit earlier in the presentation today, Ashley talked about the public health model for violence prevention. And I just want to reiterate to this group that the Cardiff model really fits well into this model. The data that is gathered and provided to the community really helps not only define and monitor the problem, but also identify risk and protective factors. And one of the ways in which we do this is by overlaying other population health statistics with the violence data. So for example, in the city of Milwaukee, we are able to look at factors such as neighborhood employment, population distribution by age group, household types and things of that nature, to really look at the intersection of violence and some of these other social determinants of health. In addition, the Cardiff model is useful for, again, developing and testing prevention strategies, and also evaluating those strategies. One of the things that the Cardiff model really does is allow a community like Milwaukee, who has a wonderful blueprint for peace, to evaluate the strategies that are being implemented through the blueprint with the data that are gathered through the Cardiff model. And then our national collaborative is really working on assuring the widespread adoption of this model across different communities in the United States. And so my process for data preparation, so I receive information on a monthly basis from a number of different sources. We currently have 3 hospitals that in our metropolitan area that provide information to me, along with our county emergency medical services and law enforcement. And as I said, I receive monthly data extracts from each of those sources. And there are some common data elements across these different sources. So the most important for the Cardiff model is the location of the assault. Sometimes that is an exact street address. Sometimes that is an intersection. All of those are geocoded and then mapped. The other data elements that I receive include the date and time of the assault, so we can look at, when violence is occurring specifically at these different locations. We look at type of assault, whether it was, a fist fight, for example, or an assault involving a firearm. We look at weapon used, and then we also have information on demographics of either the victim of the assault in some cases or the suspect, so that we can have a discussion around individuals in the community who are most affected by violence. As I said, once I receive these data from the various data sources, I clean the data, which means that sometimes, particularly with our hospital partners, I'll receive the name of a business, the Taco Bell on the corner of 60th and Capitol, for example. And so one of the ways that I clean the data is then I actually go and I find the street address for that location and manually input that into our geocoding software. I do that with all of our data sources, and then the data are de-identified and then geocoded. I use ArcMap as the platform for doing that geocoding and mapping, but I know that there are other resources out there that can be used as well for this process. One of the important considerations with the implementation of the Cardiff model is this idea of an honest broker. And this is how we are framing the data collection, linking, and sharing in our community. And so I serve as the honest broker, as the academic partners data manager. All of the data come to me. The data that I receive are de-identified already. We have some research assistants in our hospital emergency departments that actually go through and clean and de-identify the data prior to me receiving it for geocoding and linking. And then I am the person that links all of the sources in the online maps. And then I prepare the data for presentation to community partners. So our data partners really see us as kind of the entity that receives and prepares links and presents this data. It's nice to have a central person that's doing that has an IRB that's covered and that is able to do this for the community. Here are just some examples of the data that are presented to our community partners. So on the far left is an example of a map from our translation within the city of West Allis, which is a suburb of the city of Milwaukee. And you can see here that I have created a density map of the police data. So the hotspot mapping that you see is based on the West Allis police data. But the dots on the map are cases that were known to our EMS or that were came to the attention or were treated by EMS. And you can see that there are some cases that were present in our EMS records that were not known to law enforcement or did not have a corresponding law enforcement record. The middle example is from our translation within the city of Milwaukee. With the Blueprint for Peace in Milwaukee, there's been a really focused attention on neighborhoods and violence-related outcomes at the neighborhood level. And so I do our hotspot mapping, but I include a breakdown of our neighborhoods so that we can look at which neighborhoods are particularly impacted by assaultive violence. And then on the right-hand side, this is a little bit closer view of our neighborhoods within District 7 in the city of Milwaukee. And this is really showing us how many cases of assault were experienced within each neighborhood. So the larger dot means that there were more assaults within that neighborhood. And this has really led to some interesting discussions around, rates, population rates, for example. And, even though certain neighborhoods might have lower numbers, their rates of violence are actually higher due to population. And so it's really helped kind of refocus some of the discussions on neighborhoods that are truly at the highest need of intervention.
I've just been informed that we have a 1-minute warning and that it automatically cuts off. So we had just too much information. So Sarah, can you toggle to the last slide? We're more than willing to share the slides and further discuss. And please contact us with any questions. We apologize for going long and not being able to share some of the additional lessons learned that we had planned to. So thank you for joining today. I believe Dee said we're just going to, it's going to cut out. Is that correct?
Yeah, it'll probably cut out in another minute. As soon as the next session starts.
Okay.